You guys be able to see me over there? Or where's the? Okay, so you just pan over there.
Well, yeah.
I didn't just know the best place to stand.
Plan on hanging out there, or are you going to move around?
I might move around a little
It's
bit.
fine.
I don't want
we'll
to
track you if you do.
Okay, cool. Hello, everyone. I'm Dr. Blake Peterson. We're going to get started here in just a minute. We're just letting a few people log on to Facebook Live and other social media outlets and things like that. So we're going to get started here in a second. We've got about probably 45 minutes of just kind of a few slides and some examples, things we'll talk about, and then we'll make sure there's plenty of time for questions and any things you guys may want to know. It's kind of an open forum, and it's a good opportunity to ask any questions you might have and get the answers. While we got a minute, I wanted to thank Mosaic for helping us set this up, giving us the space here, and helping partner with us to advertise and work as a collaborative effort between the Orthopedic Sports Medicine Center and Mosaic Life Care to help provide good care to our patients in Northwest Missouri. Also want to take time to thank Zimmer Biomet. It's an orthopedic implant company that I use a lot for my hip and knee replacements. They have a table set up over there. They've also provided some refreshments and some cookies, it looks like, too. But if you want to, after we're done here, get a chance to go see some of the implants they use. Everyone always wants to know, what are these things made of? What do they feel like? What's the weight of these? It's a good opportunity to kind of see them in your hands and see what they look and feel like. It's a pretty neat technology, and we can talk more about that over there at the table after the talk. So I think we're up and running. And it's time to go. So the main topic today is rapid recovery. Orthopedic residency there. After that, I did a fellowship, which we'll talk a little bit about in a second, at the Peterson Orthopedic Clinic. That's in Alexandria, Virginia, so just south of Washington, D.C. It's a very high-volume joint replacement center where I got a great experience in minimally invasive and other more advanced orthopedic joint replacement techniques. So a lot of people ask, what's a fellowship? I'm the first fellowship-trained orthopedic surgeon here in North two girls. They keep us busy outside of our jobs. So back at the topic at hand, let's talk a little bit about hip and knee replacement or hip and knee arthritis. It's a really, really common problem. 81 million Americans are affected by hip and knee arthritis. The lifetime risk of developing knee arthritis, which is more common than hip, is around 45%. So you have an almost 50% chance of developing have injuries which cause traumatic arthritis. All in all, what arthritis means is a wear or an abnormal functioning of a joint where the two bones meet and they're supposed to bend and move. If they don't work properly, it's kind of classified as arthritis. As I said, osteoarthritis is the most common form. It's what you think of as wear and tear. It's from miles and use. It's all kinds of reasons go into why you might develop osteoarthritis. Having some abnormal anatomy from an injury, having trauma. Have hip and knee replacements, their parents have probably had hip and knee arthritis as well, and that's something you can't do anything about, and the longer we live, the more likely it is to have these kind of issues come up. This is a good analogy about what a normal joint is. As you think, a normal functioning joint is a well-lubricated, healthy joint. The cartilage is this nice, smooth lining that goes between the bones. It allows the bones to move with very little friction. As we age and have these things occur, that cartilage lining goes away and the motion starts to become restricted. And this is what an arthritic joint kind of functions like. It's that rusty hinge that doesn't bend or extend, and it hurts when you move it. It's not lubricated well at all, and it's painful to use. How do we figure out what you have, what's causing it? A big part of it is talking about symptoms. I ask every patient in clinic, how long have you been having these symptoms? What kind of things cause it to be worse? We talk about the severity. How severe? Is this something that wakes you up at night, or is this something that you think about once a month? Then physical exam. I make all my patients get up on an exam table, move their hip, move their knee, find out what kind of motion their hip or knee has and what kind of pain that might cause. And then x-rays. X-rays are something we do in the office. We have the ability to do digital weight-bearing x-rays right in the office and have an answer pretty quickly. A lot of people wonder, like, okay, I got it. Arthritis is a bony issue, and that's seen really with plain x-rays, and weight-bearing x-rays are the best way to evaluate that. We've got a couple examples here of what these x-rays look like. This is a normal hip. You can see on these hip x-rays there's a nice round ball and a nice round socket with good space in between the bones, so that's where the cartilage lives. Cartilage doesn't show up on x-rays because it's a soft structure, but that space that's there is because the cartilage is living there. There's no bone spurs. This is what a normal hip looks like. Contrast that with an arthritic hip. You can see that joint space is now gone. The bone's a lot whiter because it's hardened and it's seeing a lot of extra force. There's these big cysts here in the bone where the bone is inflamed and there's fluid that's actually collecting in the bone itself. There's bone spurs, and this is a very typical arthritic hip. On the knee side of things, it's again a pretty similar structure. You have nice smooth surfaces here with good joint space between the two bones. No bone spurs, no cysts, none of those white lines like we saw. The arthritic knee, those joint spaces are gone. The arthritis is basically demonstrated there by the loss of cartilage and the joint spaces being gone, and that's a stiff arthritic knee there. So let's talk a little bit about what to do about it. Now we've made the diagnosis. We've discovered, okay, I've got arthritis. Probably knew that as you're coming into the clinic. Now what to do about it. Education about the disease and what to expect is probably one of the best things that I do for patients. Telling them this isn't something that's going to just all of a sudden get dramatically worse. Talking about weight reduction. As we talked about, it's a wear and tear type of disease, so obviously body weight makes a difference. Different activities that you can modify so that you're not having as much pain, medications that can be used, and injections that can be used, cane or an ambulatory aid such as a walker, and then eventually if all these things or some of these things are no longer working, that's when we start to talk about surgery because we can very reliably make these things go away. So going down that list, weight reduction, that's the one that's kind of a taboo subject sometimes, but it does make a big difference. So every pound of upper body weight is around 6.5 times your body weight on your knee joint. So that's, if you lost 10 pounds of upper body weight, you lose about 65 pounds per square inch off your knee joint. So that's an amazing amount of pressure that comes off your knee with just a little bit of body weight loss. So one, it causes less load on your arthritic joints. Your joint may wear out slower, but the other thing is that if you do end up having surgery, it makes your surgery safer, makes you have less complications. So having surgery or having any of these things at a healthy body weight makes a really big difference. Activity modifications, as we get arthritic joints and as we have more birthdays, it's not as easy to go run the half marathon as it was when we were 18 or 20 years old. So lower impact exercises are good for the joint. They keep your joints moving, but they don't have that jarring damage that we see on joints. So things like cycling or ellipticals or water sports are all good things to keep you active while decreasing symptoms. Anti-inflammatories. This is probably the number one medication that we can prescribe or use to treat arthritis. There's many varieties. Things such as ibuprofen or Aleve, over-the-counter medications like that can do enormous good for people. There's also, a lot of folks who can't take those because of kidney disease or stomach ulcers. So things like anti-inflammatory gels like Voltaren gel, you may have heard of that. That's things you can rub on your skin that actually cause a local anti-inflammatory reaction. There are also, as we'll talk about, injections. But these are things to discuss with your physician because it gets complicated as you have kidney issues or if you have an issue of an upset stomach or stomach ulcers. It may be not in your best interest to take these. So it's something that's very important to talk with your primary care or orthopedic surgeon about. One thing you don't see on this list is opioids. Narcotics such as hydrocodone, oxycodone, those are not good for arthritis at all. They will give you very acute pain relief. Narcotics are great if you cut yourself and you have pain that's just there very temporarily. If you take narcotics for a long time, they stop working. This is the opioid crisis that we see on the news every day. There was just an article yesterday that said you're more likely to die from an opioid overdose today than you are from a car accident. So these are serious things that we really try to keep people from taking. And they don't work long term. Your body becomes resistant to them, and what used to take 1 or 2 pills now takes 5 or 6 pills, and that's when we start to get into issues where dependence and the high risk for overdose starts to be a real thing to worry about. So we work really hard with our primary care providers to try to stay away from these, and they do a great job of keeping patients off of these until we need them for things like surgery, an acute pain, a very short-term pain that goes away with time. A lot of folks have injections. Injections aren't necessary if it's not this box that you have to check before surgery, but that being said, they are often very helpful to have. The most helpful of these injections, the ones that have the best literature, are steroid injections, cortisone shots. This is an anti-inflammatory that provides basically a high dose of pain relief and anti-inflammatory directly in the joint. There is some evidence that corticosteroids, cortisone, steroid injections, can cause your cartilage to wear out a little bit more quickly over time. So this is why we don't offer this in 20, 25-year-old kids. And it's also why we don't do them more than 3 or 4 times per year, because it can start to have some effects where it just really doesn't work as well as it used to, and it can cause some damage with really prolonged long-term use. Other things that you've probably heard of, lubricating injections. These are called viscosupplementation injections. Synvisc, rooster comb injections, all the same thing. The idea behind these injections was that it was going to lubricate your joint, allow your joint to start moving better, and give you some fluid that's going to basically grease the joint. Unfortunately, there's been a lot of recent literature where we've compared these injections with saline injections, just salt water, and unfortunately the results show there's very little difference between the two. So because of that, as you can imagine, insurance companies have said, we're not going to pay for this. This is an $1,100 injection. We're not going to pay for something that is just as good as salt water. So more and more people are moving away from this because it doesn't seem to have the effect that we thought it did, and it doesn't seem to be as useful as we hoped it would be. One that's kind of on the rise and you see more and more about is stem cell injections or PRP injections. That's platelet-rich plasma. Those are where you take some of your own body tissues. They can be from your adipose, your fat cells. They can be from your plasma, or where they draw blood. This has some early evidence to show that it can be beneficial in very early arthritis, particularly that platelet-rich plasma. These aren't covered by insurance yet, so there is an out-of-pocket expense. Platelet-rich plasma injections, for example, are around $300 is what most offices will charge for that. It costs about $150, $200, so for them to recoup their costs and their time, it's usually around $300 is what people charge. Stem cell injections, however, are really expensive. I mean, you'll see people charging $2,000, $3,000 for these, and those are surprisingly some of the ones that have the worst evidence that they are not effective. So it's not something that we typically recommend for our patients because we have yet to see any data that shows that it's effective for treating that pain. Supplements, a lot of people take glucosamine or chondroitin. These are things that, again, have some data that show that they can be a very weak anti-inflammatory that can cause some pain relief. There's probably not a whole lot of harm in it, but the unfortunate thing, as with most supplements, they're not FDA regulated, so we don't know exactly what's in each supplement, and it's not as strictly regulated as most medications are. So all that being said, there's probably not very many side effects with these supplements. But they probably don't have a huge effect. You're not going to just all of a sudden start running down the hallway after taking a little bit of glucosamine. After all these things fail, that's when we start talking about surgery. People have had injections, they've been using a cane, they're having a hard time, and they just really get to the point where their joint is keeping them from doing the things they love to do. That's when we talk about surgery. So the patients who are good joint replacement candidates are not satisfied with all these treatments. They're medically optimized, as we'll talk about in a minute. They have the health to be able to undergo a fairly large procedure, and they understand the risks and benefits and what to expect in the recovery. So surgery for hip and knee arthritis is performed on about 1 million patients annually, and that's growing every single year as the baby boomer population continues to age. We're seeing more and more people needing joint replacements. The goals of surgery are really very simple. It's to relieve pain and increase mobility. This allows our patients to return to the active, fulfilling lifestyle that they are missing because of their painful joint. So what to do before surgery? We'll talk about this in depth here in a moment, but really what it comes down to is after the decision with your surgeon's made that surgery is the right step, we want to make sure that you're safe to have an operation. We send most patients to their primary care physician or perhaps the hospitalist or someone to evaluate them to ensure that they are safe to undergo an operation. That may involve a cardiology clearance or an EKG or something, really just to make sure there's all of our T's are crossed and our I's are dotted. And then there's a pre-op education class, which we'll talk about as well. Let's go a little bit into the procedures. We'll talk more, and I bet this is probably where a lot of the questions will come about the procedures themselves. I'm going to touch very briefly on hips and knee replacement. Hip replacement here, this kind of shows you quickly what the implants look like, and you'll be able to see them over here on the table. But what you do is you replace the diseased hip joint with a metal and plastic articulation. So the way that you do that is you expose the joint. There's lots of ways to get down to a hip joint. There's at least 4 different approaches, which you'll hear the pros and cons about a little bit here. But go down, you remove the arthritic head, you prepare the socket by reaming or removing the diseased cartilage, putting a new socket component in. It's a hemispherical titanium shell that goes into the socket, and then there's a plastic liner that goes inside of that. And then the stem side, there's a titanium stem, as you see, that goes into the canal of the femur there. That's one that has an ingrowth surface typically where the bone grows into these implants. So the implants are basically, after about 6 to 8 weeks, stuck to your body to the point where it'd be pretty difficult to take them out if you tried. And then after you've done a few maneuvers and taken some x-rays in the operating room to make sure that we've recreated normal anatomy, we place these final implants, which you can take a look at. The way that I do hip replacement, as I kind of briefly mentioned, there's a lot of different ways to do joint replacements or get down to the hip. I do what's called an anterior approach hip replacement. Some people call this a minimally invasive hip replacement. I do not like that word for a few reasons we'll talk about, but what this involves is making an incision on the front of the hip. So you go between the muscles rather than cutting through the muscles. This allows me to go down to the hip joint and replace the hip without having to detach the muscles from the hip. If you look at all different types of hip replacements that are done, really after a year the results are pretty much the same. Once you've got good implants and good position, they're probably all going to do well after a year. It's the first 4 to 6 weeks that an anterior approach has showed more and more improvements. And that's probably because we're not disrupting these muscles as much. There's no hip precaution, so you can move your leg any way you want. And most people are able to weight bear immediately with, use a walker for a week, and transition to a cane for a week, and then off to the races after that. So those are those are some of the advantages. By doing this surgery, we use a special table and some x-ray. We're able to really, really precisely do surgery so that I know that the hip replacement is put in the exact place that I want it to be and that the hip anatomy is corrected perfectly. The benefits of the anterior approach: less trauma to the body, as I said, small incision, not detaching muscles. People are able to get up and move very easily. Potentially less pain. I'd say most of my patients after an anterior hip replacement use less than 10 narcotic pain pills. There's less need for medications such as those narcotics. It's a faster recovery. Less restrictions, as there's no hip precautions. You may have heard of people having a hip replacement where they can't bend their leg, they can't cross their legs. None of that stuff exists for an anterior hip. And then there's hopefully less complications because of that, because it's a safer surgery. We try to make our surgeries patient-proof, so no matter what the patients go out and do, then hopefully they can't mess it up. But it's getting close, but it's not quite there. We'll talk more about hip replacement, and we'll be sure to answer some questions about that. A quick overview of knee replacement. Knee replacement is a surgical procedure where we remove the arthritic joint, cut out the diseased, scarred down, thickened bone, and replace it with a metal and plastic implant, oftentimes with cement, but there are some cementless knee implants that are being used more and more now. There's two types of knee replacement, actually. So there is a total knee replacement, which, as the word suggests, you replace the entire knee. You cut out the ACL and the PCL, and you replace both sides of the knee and under the kneecap, and you basically start from scratch. A partial knee replacement, or a unicompartmental knee replacement, all these things are the same thing that you've probably heard about. This is where you go in and you replace just the diseased part of the knee. So if you have a wear pattern that is good for this, it's a little bit faster recovery. It cuts the knee replacement recovery almost in half, and it also has less risks. Now, if your knee is completely worn out and it's too far gone, this isn't an option. But picking patients who are good candidates for this will make your recovery better and hopefully prevent having an unnecessarily large procedure. The steps for this are very similar to the steps of a hip replacement, just a little bit further down on the body. You expose the knee joint, reshape the bone ends with a saw, so you cut those off. Make sure that the ligaments give your knee a nice even range of motion, and cement these implants typically in place. You'll get a good view of these implants over there, and I'd be glad to meet you over at the table and kind of go over those and talk about them more in depth here. So everyone wants to know, how long is this going to last? If I'm a 50-year-old guy, am I going to be able to, is this my last surgery? And the answer is we don't know anymore. We made a pretty dramatic change to the plastic. The plastic was the part that wore out the most. We made a pretty dramatic change around the year 2000. Prior to year 2000, the hips and knees that we were putting in were lasting somewhere around 15 years. So folks that I've been seeing, that had a knee or a hip done in 99, 98, they're coming into clinic and they're starting to show some signs of wear. People that have the newer plastic, the stuff that's been put in since about year 2000, really are showing very, very little wear. I think it's safe to say 20 years. I think 30 years is a reasonable expectation, and that's probably a conservative expectation. The wear rates that we see are about 0.1 millimeters per year, so it's incredibly low. The overall survivorship, so if you said, what are the odds that in 20 years I'm going to have this knee and I'm going to like it? The failure rate's about 0.5 to 1% per year, so that means around 90 to 95% will be functioning well at 10 years. And 80 to 85% will be functioning really well at 20 years. So you can tell you that you have a great chance that your knee will be functioning well 20 years after surgery. So what's changed? This is getting into the idea about how have we made joint replacement easier to get over, because that's really what's changed. Beyond that change to the plastic and the change to the implants I talked about, our way that we think about joint replacement has changed over the decades quite a bit. Back in the 1980s, joint replacement in the 70s and 80s was really experimental. We didn't really know how we were going to go about this. We were using implants that were oftentimes custom made, and we were oftentimes casting patients after surgery, keeping them on bed rest, staying in the hospital for up to a month. This is back when orthopedic wards were infirmaries of patients in traction and patients laying in beds for months. So this is one that had variable results. There are some hip replacements that we luckily found out worked pretty well back then, but that was pretty much by luck, actually. In the 90s, we started to figure out the implants. We started to figure out the surgery, and we thought, okay, we can do this operation, but to do this operation, it's such a big injury to the patient that we have to control their pain. Unfortunately, we were doing the pain control wrong. We were giving patients lots of narcotics. You probably remember the days when patients would have what's called a PCA, a patient-controlled analgesia. It's where you push a button and you get narcotics put in your IV. Patients, as you could imagine, stayed around the hospital for 5 to 7 days because they were basically hung over from the anesthesia, hung over from the pain meds, and unable to get up and move. The complications were more prevalent, such as blood clots and pneumonia, because we were laying in bed hurting too badly. In the 2000s, we thought, okay, if this surgery is just too hard to get over, maybe we just need to make the surgery smaller. So we made our incisions really small, and the implant manufacturers made all these really neat, minimally invasive techniques where we could try to do the surgery through really small holes. Problem there was we found that the surgery became really, really difficult to do. We had a lot of complications such as fractures and implants being put in the wrong position because we couldn't see what we were doing. So we found out that perhaps maybe doing surgery to the smallest incision wasn't the best idea. Joint replacement today has really changed into this multimodal approach, is what we call it. We look at all the different ways that joint replacement can be affected. And we're going to go through each of these 6 kind of phases that I think about how to make my patients get through surgery more easily. The first thing is mobility. I think that getting back on your feet as fast and back to normal as fast as possible after surgery is the most important thing that I can do. So many of the side effects to surgery are secondary to restrictions that we had to try to protect our surgery. So we tell people, no, you can't put weight on your hip. It's just, you got to wait 6 to 8 weeks because it's not ready for you to put weight on it yet. We tell people they couldn't cross their legs or bend their legs and that made it really hard to get around, so patients would be very apprehensive to move at all. We tell folks on your knee, don't bend your knee replacement yet. You can't do anything. We want you to hold it still. This was, as I said, a delicate balance for the surgeon. We could make our x-rays look really good and try to prevent complications from the implant side of things if we just put our patient back on bed rest. But it didn't make our patients get better any faster. So all the complications that we would see, like pneumonia and blood clots and wound healing issues, would be more prevalent. So education. Education is this part of the continuum that I will take through my patient from the day I meet them in the office to the OR to the post-op to their 6-week appointment. It starts with the discussion in the office. I give them a pretty good little talk about what to expect. I send them home with reading material because I can't imagine how hard it is to retain all the things we just talked about during that office visit when you just found out you're probably going to have your joint replaced. I then have everyone who's having the surgery see the folks in our joint class where we go over all these things, reiterate these points, talk about what the recovery is going to be like. The physical therapist will talk about what kind of expectations to have and evaluate them. And then in the hospital, our nurses and our therapists and physicians will help educate the patient more and more. And then post-operatively, we talk about these things at every visit and even between visits. Ways that we communicate with our patients, I've been really good about trying to get all this information on our webpage. Our webpage address is OSMC Ortho, and you'll have my webpage here at the last slide. It's just petersonhipandknee.com that redirects you to all these things so that we can educate our patients about what to expect throughout their recovery. The next step that I worry about is risk stratification. I think about what kind of patients are able to undergo a surgery safely, because surgery is trauma. It is something that you have to get over, and sometimes if you're a very frail elderly person or a frail young person who has a lot of medical problems, it can be too much to handle. So I have everyone, as we talked about, have a comprehensive medical evaluation. You can see I've put clearance, medical clearance in quotations, because no one's ever really clear for surgery. You're just optimized. You're at your best you're going to be. We can just get you tuned up as much as possible and realize how much risk does this person have versus that person and determine whether that risk is worth having surgery. And then after surgery, we have our hospitalists and primary care providers provide medical coverage to make sure that our medications and things like that are not changed after surgery and that everyone's recovering from surgery safely. The things I ask patients in the clinic that I worry about specifically are, who do you live with? Because if you are an 85-year-old woman who lives alone, having a big operation may be difficult to go back home. So I want to know if you live with someone, if you don't live with someone, who's willing to commit 1 to 2 weeks to kind of your recovery, and who's there for you to help you recover. How many stairs do you have? Stairs are something that scare a lot of people after surgery. I tell most of my hip and knee replacements that you can probably go upstairs better the day after surgery than you could the day before surgery. It's more of a thing of learning how to do it safely, and our physical therapists help our patients learn how to do that in a safe manner. We get them out in the stairwell out here in the hospital and show them how easy it is to do. And then I want to know, at baseline, are you using a cane? Are you someone that's already in a wheelchair? If someone's in a wheelchair and can't get up on the exam table, I know that doing surgery on them is going to be a pretty big hit. It's going to be difficult to get over that because they're already at a phase where they don't have a lot of strength, and they are going to need some strength to get themselves up and moving. Pre-op planning. So this is something that we've done a really great job with here at Mosaic and with our orthopedic clinic. This involves both surgical planning, talking with our implant companies and thinking about what my plan is for this particular operation, as well as meeting with all the teams that are involved to make sure that we know what each individual patient is going to undergo. So I know the plan of the surgery stay. I know what's going to happen after surgery. This is what I do for every single patient. This is an example of preoperative templating. I look at the deformity that patients have. I look at the particular anatomy they have. I figure out what size implants I'm going to use. I make sure that all these things are in stock, available. We have great support here where we can pretty much get anything we need, but I want to know ahead of time if there's something special that I might encounter in that case. That allows me and the operative team, my surgical assistants and scrub techs, to expect those things, and being able to expect them will prevent any surprises in the operating room. This is something we just did about an hour and a half ago. I meet with the social workers, care management, nurses, physical therapists, administrators about 2 weeks before everyone's surgery. I go over their preoperative clearance. I talk about what our plan is surgically. Our implant reps are there, and we talk about sizes of implants that we're going to use. I want to know, is there anything special this patient's going to need for therapy? Is there anything surgical supplies-wise that I need to get ordered in or that we're going to have to encounter? I want to make sure the patient's not going to get hit with some kind of big bill that we weren't expecting because they have some obscure insurance plan that the hospital didn't know about. And then I want to know what their plan is after surgery. Is this someone who's going to do outpatient therapy? Are they going to do home health? Who's going to be there to help them? We talk about all these for every single patient that I'm going to operate on. And this is something that allows us to know the plan ahead of time rather than having to try to do a surgery and then decide 5 minutes after their surgery, oh my gosh, what are we going to do for this patient? They don't have anyone at home. This is stuff that we should know ahead of time if you think about it. The surgery itself is probably one of the smallest pieces of this entire puzzle. I don't like the word minimally invasive surgery because, as I talked about, those small incisions oftentimes have small problems, but efficient surgery is what I really try to perform. I don't want this to be a race. I don't want to do things sloppily. But I do want to know that surgery is trauma. So the longer I'm in the operating room, the more risk they have for infection, the less trauma I expose the patient to with pulling on nerves, pulling on tendons, the longer it's going to be for them to recover if they have those things happen. So an efficient surgery decreases muscle damage. It has small incision, but not so small that I'm stretching things just to see what I need to see. It minimizes blood loss, and it minimizes stretching all those nerves and tissues that can be really irritated. Pain control. Everyone's worried about pain after a joint replacement. I think of pain control in 3 phases. Preoperatively, as I talked about, trying to avoid narcotics, trying to avoid those medications which set you up for failure to start with. Intraoperatively, things that I can do during surgery to try to prevent pain after. And then after surgery, having a good plan and a good understanding of how to use those medications. So the number one way that I can make this, and to make this surgery easier, is regional anesthesia. We'll talk a little bit here about what this is, and this is probably the number one thing that makes joint replacements easier than it used to be. So regional anesthesia is the use of both spinal and epidural anesthesia, as well as different kinds of blocks where the anesthesiologist can inject numbing medicine to block or numb the area that we're going to be operating on. This is usually done with ultrasound, and that can improve the accuracy and the safety of this. So what a spinal or an epidural anesthesia is where they inject numbing medication around your spinal canal. That sounds dangerous, sounds scary, right? This is the same thing that our anesthesiologists do for our pregnant and laboring women every day. They do it all the time, and it's a very safe way to have surgery. It is the safest way to have surgery. There's less blood loss. There's less risk of having breathing problems. You don't have to have a breathing tube. You don't have to have a catheter. You don't have to have any of those things. We give you a little bit of sedation during surgery so you don't hear all the saws. You take a nice little nap. You wake up, you start wiggling your toes within a couple minutes, 30, 40 minutes after surgery, and you wake up pretty refreshed. So it's a nice way to have an operation. It's especially safe for people that have medical problems like heart or lung issues because we don't alter those. We basically numb your body in the part that we're operating in, give you enough medicine so you're comfortable, the same kind of twilight sleep that you have for your colonoscopies, and allow you to have an operation in a very safe manner. Again, post-op patients will need some narcotics after surgery. Most patients, particularly knees. Knees hurt a little bit more than hips. You've probably all heard that, but minimizing the use of those and using them safely and effectively is really important. So I'll oftentimes give my patients medications such as tramadol, which you can take for more mild pain, and then hydrocodone, which you take for the more severe breakthrough, kind of keep you up at night pain. That acute pain phase should last less than 2 weeks. After 2 weeks, you should kind of be at the point where you're kind of getting over things and not feeling as painful and needing the narcotics. But not getting hooked onto them and not going months and months on pain medications is really important to having a good, successful outcome. Again, going back to mobility, after surgery now, our physical therapist will get our patients up on the day of surgery, just a couple hours after surgery. Our outpatient joint replacements, that is the patients who go home the same day, they're up within an hour of the operation, up walking. Most patients are weight bearing as tolerated, so they can get up and put as much weight on it as they can tolerate. They have no range of motion restrictions, very rare to have hip precautions. You know, that would be more of a revision or a complex surgery. We expect them to get up and move after surgery, and we talk about what to expect, the transition from a walker to a cane to walking independently. And then we talk about what kind of DME, so that is what kind of equipment do you need? Do you have a walker? Do you need one? We figure that out ahead of time so that we can make sure that all those arrangements are made. This is a neat little slide here. So this is one of the great things that I've been using in my practice that was pioneered by one of my fellowship attendings. This is an application called Pulse. So this is how I educate my patients and communicate with them throughout the surgery and after surgery. So let's say you're a patient that had a joint replacement and you're 15 days out from surgery. It's going to ask you these questions every day. For example, it's going to say, how much pain are you having? You go through here and you put your pain scale in. It's going to ask you how well you're walking around. You say, I'm walking around my house. Are you having any fever or any signs of infection? Are you having bowel movements? Can you walk around with your walker? You go through these questions, and then it can say, okay, thank you for answering these questions. Let's do some exercises. And this shows you the exercises that you're supposed to do today. For example, this is shows you a little video of how to do a straight leg raise. So the exercises are customized for each type of surgery that you have, and they're customized for what day you had surgery. So if you're 15 days out from surgery, your exercises are different than if you're 40 days out from surgery. This helps augment a lot of the things that our physical therapists are doing. This demonstrates probably the best aspect of this application. That's contact with me. So this application allows the patient to securely and with HIPAA compliance message the doctor and his team or his or her team and ask questions. For example, this patient's about 15 days out and they forgot, when can I take my dressing off? Do I need to keep this bandage on? So they message me. It comes directly to my phone as a push notification. So if me or one of my assistants sees that, this is for non-urgent issues. So if I'm doing something with my family, I'm probably not going to answer this, but I'll probably get back to you within an hour or two because as you know, most people my age are hard to get away from their telephones. So I get this message on my phone and Jane's asked, can I take my dressing off? And I could quickly respond to her and say, yes, send me a photo of it after you've done so. So then she can actually take her dressing off and then going back to what she's done here, she sent me a photo of it. And I can take a look. This is an anterior hip incision, kind of what they look like. And I said, okay, that looks great. See you in 2 weeks. Because I usually see patients about 4 weeks out. They take their dressing off about 2 weeks after surgery. So this allows me to have constant contact with patients that are not having problems, patients that are having problems, that have just questions that fall through the cracks. This allows you to get a hold of me on a Saturday afternoon if you need to. So it's a nice, easy way to continue to have comfort in your recovery. So this is a few examples. We talked a lot about what joint replacement's like, what joint replacement can be like, and sometimes the proof's in the pudding and seeing what patients can actually do. So this is a guy that's 2 hours out after a joint replacement. He's getting ready to go home. Mo, one of our physical therapists, is out walking him in the recovery room. And you can see just 2 hours out after surgery, walking with a walker, because again, our whole goal is just don't fall. We want to, you're not walking as normally as you used to. You've got a whole new hip. But you can see walking without much pain there in the recovery room. Here's an example of a knee. This is a guy who's 16 hours out from his knee replacement, rounding on him the morning after surgery. Great range of motion, really no pain. This shows you an example of what my dressings look like. It's this waterproof dressing that stays in place for about 10 to 14 days, and you take it off at home. There's no staples. It's absorbable sutures with glue, so you don't have to worry about suture removal and things like that. But good pain relief, good surgical plan, efficient surgery, and motivated patients can result in outcomes like this. And then long term, what do patients do? This is a patient I did a bilateral hip replacement. So that means I replaced both of her hips about a month before this video was taken. So both of her hips at the same time. And you can see she came into my office using a walker and a cane, kind of hunched over, having a hard time walking because both her hips were so arthritic. And you can see she's walking down the office here at our clinic with really very little pain. You see she's got a nice smile on her face as she comes around the corner there. So the outcomes of surgery can be very, very successful. This is a surgery that has the biggest quality of life improvement of any operation we can do in America. It has excellent long-term results. These will last most people the rest of their life. Patients are very, very happy, and recovery can be a lot easier than it used to be. This is how you can get a hold of me. We'll leave this slide up here at the end in case you want to jot down numbers or things like that. The office number there is our clinic's number. You can make appointments. We can talk about things more or get any more information. The webpage at the bottom, petersonhipandknee.com, is just a forward to our practices webpage that allows you to access some of our patient education material. And if you use social media, Twitter, Facebook, Instagram, you can find me at Blake Peterson, MD, posting videos and educational content there as well. So I think that's going to be about it. We'll go back to this slide so you guys can leave that. Let's open the floor up to any questions that people might have, if there are any. And if there's anything that came up on Facebook Live, we'd be glad to answer anything there as well. Yeah?
I've already had a total left hip replaced. I have no cartilage in my right hip. I've had no problems with up, break, pain was not a problem, nothing. But I'm raising a 6-year-old, so I need to get back on my feet faster.
Yeah. So the comment was that she's had a hip replacement done before and having arthritis on the other hip. And even though the surgery went really well, I think that the improvements that we've made in recovery and not having hip precautions and being able to get back to your life a little bit more quickly are the goals of all the operation that we're talking about.
How fast can I drive after that?
That's a great question. The question was, how fast can you drive after surgery? And my restriction is whenever you're not taking pain medication. So most people after hip operations can drive very safely within a week. Most patients with a knee replacement, if it's their right knee, it takes a little bit longer to be able to use the pedals safely. So I don't put a restriction on time per se, but I do say when you're able to safely drive without pain medications, go to a place such as a parking lot that's empty and test it a little bit. Make sure that if something were to jump out in front of your car that you'd be able to quickly stop. And most knee replacements, that occurs sometime around 2 to 3 weeks. Good question. Yes?
The knee replacement that you showed us, is that different than what the orthopedic other surgeons do?
So the
knee replacement that you showed us,
yeah.
is that a different approach than what the orthopedic,
My partners do? No. So the knee replacement stuff that we do is very, very similar. I think that as a group, we're working to bring most of our protocols and our post-operative recovery things as equal as we can so that there's less confusion for nurses post-op and that we see what works for other people and we try to make that our practices, guidelines. But we all use pretty much the same joint replacement parts and we all use just variations of the same theme on how to do the joint replacement. It's the recovery and the planning and things like that we're trying to standardize and make that basically what we do as a group. But yeah, the parts are pretty much the same, and the operation really hasn't changed a whole lot over the past 10, 15 years. Yeah.
preference of doing one at a time or doing both at the same time?
That's a great question. So the question was whether or not, if you have arthritic knees on both sides, whether you should have them done at the same time or if you should do them separately. And that is a very, very patient-specific question. So as far as the outcomes in the literature, they show that they are pretty similar in how you recover. So if you were to have one knee done tomorrow and then the other one done 4 weeks later versus having both knees done tomorrow, your recovery is not all that different. The reason being that having them both done at the same time is a big operation. It just takes longer to get over. But having one done at a time and then staging them gives you, quite literally, a good leg to stand on during your recovery. So the biggest thing to consider when considering whether you should have both knees done at the same time is whether you're healthy enough to have that operation. There's some literature out of the Mayo Clinic that says if you're over 80 years old, you may want to consider having them done one at a time. But that generalization doesn't apply to all 80-year-olds. So some 80, 82-year-olds are healthy enough to still have that operation because they have the health of more like a 60-year-old. So really making sure that you're healthy enough, that your heart and lungs could withstand it, and that you have the strength to recover from a pretty big operation. Absolutely. What's up?
I'm obviously overweight. Well, I am. I realize that. If, do you have a weight restriction?
So,
Like,
right.
I would come in and see you and say, yeah, you have no problem, you can't walk, you're using a cane, you're trying to
Sure.
6-year-old, but you need to lose 30 pounds.
Right. So the question was, is there a weight restriction for joint replacement? And that again comes to risk stratification, so determining how risky is it to have an operation. So the BMI, or your body mass index, is basically your height divided by your weight with some square rooting in there. If you type in BMI calculator on the internet, you can figure out what your BMI is. The magic number is 40. So a BMI less than 40 has been shown to have less risk than a BMI greater than 40. Now again, that's a generalization. That doesn't say that someone who's got a BMI of 38 but has uncontrolled diabetes and heart disease is any healthier than a person who has BMI of 42 but has none of those medical problems, is just a big husky man. So each person needs to be looked at individually, but that's kind of the soft measurement. So as we continue to strive for protocol-driven joint replacement, we kind of, at this hospital, are thinking is BMI of 40 unless there's justification for it. So if there's risk stratification and discussion about why this patient should have a surgery despite being over that limit, then I think that it can be justified. But again, it's a very patient-specific thing. BMI of 40, if you're under 40, it's pretty much a no issue. But after that, we have to really look at it very, very closely. Yes?
What about physical therapy after surgery?
Very good. So the question is, what about physical therapy after surgery? Physical therapists do a great job after surgery of helping our patients recover in a very, very safe and controlled manner. Young patients who have hip replacements, particularly anterior hip replacements, are often finding that they need less guidance from a physical therapist, and sometimes that guidance is maybe a little bit more delayed. So this initial time when they're just walking around and learning to get around the house more safely, maybe they don't need the therapist for home health. But we're finding that our joint replacement patients are oftentimes going directly to outpatient therapy, so going to our partners at physical therapy facilities around town after their surgery 2 or 3 days later is often beneficial. Knee replacements, however, they often do need physical therapy just because that joint is one that is a little bit hesitant to move after surgery, and oftentimes people need just a little bit of coaching to get that knee moving more efficiently. So again, it's a patient-specific thing. Our more debilitated, weaker patients benefit from it more. If I did a hip replacement tomorrow on a 42-year-old gentleman that goes home the same day, he can probably be able to do exercises at home and get by just fine. Yes?
How long from when you make your appointment to scheduling surgery?
Yeah.
2 months, 3 months?
So each surgeon's different. I strive for about 8 weeks, 6 to 8 weeks. So, and the reason for that being is it allows me to keep my surgery schedule very, very consistent. I like to do 6 joint replacements on Thursdays and 3 or so on Tuesdays. But in that process, when I see patients in clinic, they do have to see their medical doctor. Some people need to see a cardiologist. And let's say someone saw a cardiologist that said, well, you might need to have stents done first. You have a heart disease that could give you a heart attack if you have surgery. I want to be able to cancel that surgery or postpone that surgery and find someone else to take that spot so that everyone else has an opportunity to move through the operating room efficiently. And it usually takes around 6 weeks to make sure that we're able to do that with good efficiency and not have, empty OR space. Yeah.
Oh, well, just a scenario, what if you had 2 arthritic knees and a bad hip? What would typically go first?
Good question. So the question is, if you have 2 arthritic knees and a bad hip, what do you do first? How do you manage that? And again, it's which ones bother you the most? Those are the questions I ask patients. I said, which ones keep you from doing things that you're having a hard time doing? If everyone says, they're really pretty equal, I realize that patients probably recover from a knee replacement if they have good hips. So I'll oftentimes start at the top and work down. So if it's really kind of dealer's choice, I'll just elect to do a hip first because I know that's a little bit easier recovery. Get that hip fixed, and then you can really focus on the knees. If one bothers you more than the other, then obviously that's the one you go for first. Yeah.
When do you go home after knee replacement?
So around a little over 98% of my patients have gone home within 30 hours of their surgery, hip or knee replacement. So most patients go home. They do therapy at 10 a.m. the morning after surgery, and they usually go home right after that sometime. It just really depends on the biggest delay in going home is getting a ride. So they're waiting for someone to get off work to bring them home. Yeah.
Your Pulse app really
Yeah.
intrigues me on the home health nurse.
Yeah.
Is that available for us too, that we could take a picture for patients?
Yeah.
How
So
do we-
So if my patients have it, you guys are more than welcome to use their phones and help them use it. I am starting to work with think about working with some home health agencies to give them a login and make them a care provider as well, and then start assigning patients to them. So that's kind of the next phase that I've had a lot of people ask that same question. So with the Pulse app, empowering some of our providers to do that. We just recently had some of our nurses on the floor help sign patients up so they now have access to it too. So I think that's the next logical step.
So we don't have access now. If the patient
Not
really
yet.
doesn't have an iPhone or a smartphone, would we still have access?
If they don't have a smartphone or iPhone, I usually ask them, does one of your kids? Because usually the answer is yes. So I usually sign up their kids to do it if that's the case, because they'll help mom and dad get questions asked if they need to. But yeah, that's the next step. Makes sense, right? To have our home health agencies have access to that as well. All right. Very good. Yeah, go ahead. I like it.
As I said before, I had my left hip
Mm-hmm.
from one of your partners.
Sure.
Would that be like stepping on it?
No. No. Great question. So the question was if you've had a joint replacement by one of my partners or any other surgeon, and that is that stepping on toes to try to switch surgeons. And no, we're a very collaborative group. We, the power of our group is that we have 6 amazing orthopedic surgeons who are all willing and able to collaborate. As I talked about, we'll do surgery together oftentimes. We'll do things to make sure that every one of us succeeds. So no worries or concerns there. We swap and trade patients all the time, and even when we don't swap and trade them, we ask questions to each other about what would you do in this scenario. So that's definitely something that we encourage, and we want our patients to be happy. Yeah.
Well, I know this is a hip and knee
Sure.
session, but I have problems with the drop foot.
Yeah.
That is causing the knee to hurt more and more all the time. And I've gone to like a chiropractor, and like one day I was at 10 different places because one will cause something else to go out.
Yeah.
And so I'm just at the point where I need to know where to start.
Sure. So there's lots of reasons that people can. The question was specifically about a drop foot, and so lots of things that can cause a drop
The
foot.
arches,
Oh, so is it actually a flat foot or a drop?
it's a drop, yeah.
Okay.
I mean, you can tell it's not right.
Sure.
And I've worn like these
Oh,
shoes
inserts and
the
stuff, yeah.
arch support in my shoe for
Yeah.
years.
So oftentimes, foot problems can cause knee problems, which can
Yeah,
cause hip problems.
right.
So, for example, a flat foot can cause you to wear out the outside part of your knees because you're becoming more knock-kneed from a flat foot. So we do look at the entire alignment of folks, and oftentimes it's about determining what's the root of the problem. Is the reason that someone's foot is flat because their knee's worn out, or is the reason their knee hurts because their foot's flat? That usually requires a physical exam, and even if one of my partners or myself can't figure out what's going on, we have a lot of partners in the community that do foot and ankle work that we will be glad to help refer to and get. We serve as a great way to get our patients to the right person. So even we've got providers that are available on a walk-in basis. You can just call and see us that same day. We're glad to help get you to the right people to help take care of whatever problem it might be. Yeah.
So, as you know, people talk to each other. So, a lot of my patients will say, well, so-and-so said they had pain for this long. So how do you counteract the anticipatory sensory response to pain
Yeah.
prior to surgery or prior to rehab?
I think that's a great question. The question was, how do you, when patients talk about what to expect after surgery, perhaps they talk to someone who had a bad experience, and they've had a lot of pain, and they're kind of expecting that, and that amps up their nerves. And I think there's a couple ways that we counteract that. One being just education throughout the entire continuum of care, talking about realistic expectations, and then having them meet those expectations each time we see them. So whether it's me seeing them in the office, whether it's the folks seeing them in preoperative class, whether it's our physical therapist seeing them in a pre-op visit, all those ways are great ways to have the patient have a really good understanding of what to expect after surgery. But honestly, there's not a great way to just, each person reacts differently. So trying to make those expectations reasonable and realistic, and then also, just being there to support them when they get to that point and saying, okay, this is normal. Don't worry about this. And that's, I think, one of the ways the Pulse app works great, because I'll have patients say, man, it really hurts. Is this normal to be hurting at day 3 like this? And I'll be able to either call them or message them back and say, yeah, this is very, very normal. Don't worry about this. This is going to pass with time. And they're usually pretty grateful. Just to have that reassurance is helpful. Good. Yeah.
Do you encourage your patients to want to do this outpatient?
Great question. So the question was, and we didn't really even touch on this, was do you encourage patients to have this as an outpatient or to have this in the hospital? And the answer is, depends on the patient, and sometimes it depends on their insurance too. For example, Medicare won't allow some patients to have surgery as an outpatient at a surgery center, but private pay insurance has realized that there are some cost benefits for this. So we can do a surgery at a surgery center, such as that hip replacement that you saw a video on. That could have been done at a surgery center where they could have gone home from there, and it can cost the entire healthcare system a lot less money. It's about 60% cheaper, or 60% the cost to have a joint replacement at a surgery center than it is at a hospital, just because a hospital is geared up for all these big complex operations. So if you take all that complex stuff out of it and make it a very streamlined system, you can save a lot of money, and insurance companies have realized they save money. As you know, insurance, that's their goal. So it's a great way to have a safe surgery. I encourage patients who are healthy enough, who have an insurance that will pay for it, that an outpatient surgery by far has the best patient outcomes as far as patient satisfaction. If you ask patients who went home the same day, were you happy? They're more likely to say yes than someone who stayed 3 days in the hospital. Yeah.
In my job, I walk around the hospital all day long. How soon after surgery would I be able to get back to work? Just normal weight bearing?
Yeah, normal weight bearing. The question was, if someone were walking a lot or doing whatever during work, how soon can you get back to work? And the thing that I tell patients after surgery is most patients who have a desk job usually can go back around 3, 4, 5 weeks. Patients who have a manual labor job are looking more at 6 to 8 weeks. Your description of someone who walks around most of the day probably falls in between there. You're not slugging concrete, but you're also not sitting at a desk. So I tell people also that when you're discussing a potential surgery with your employer, it's always best to kind of undersell and overdeliver. So tell your employers that you might be out for as long as you possibly think you might be. If you want to come back early, they're probably not going to say no.
surgeon, are there any precautionary measures that you would take for an individual 90 years of age?
So the question was, as a surgeon, is there anything that I look at, and particularly with patients that are around 90 years of age or even more? And I look at each patient in that age range is a little bit of a high risk, right? So the risk of cardiac issues during surgery is slightly higher, but as you get to be into your 90s, the risk of cardiac issues as you go from 90 to 91 isn't low. So we have a really in-depth discussion with our medical doctors and with our cardiologists to make sure that we're doing surgery as safe as possible and that it's the right thing to do for patients. And this is where I think spinal anesthesia can be the best way to have an operation. So if patients have a little bit of heart disease or if they have some lung disease, if you take the hangover of a general anesthesia out of the equation, patients can recover a lot more safely. It's a lot less stress on the body. And I make sure that I have as little blood loss as possible so that we're not stressing that body as little as we can. And that being said, if I have yet to operate on anyone over 90 here yet. I've done plenty of operations on patients over 90, but not since I've been back in St. Joe. But I think that I would be surprised if someone went home the next day. I would probably be a little more cautious and say, you know what, let's make sure that you are 100% ready to go home before you go home, because the worst thing I could do is send someone home too early. And kind of caveat to that, we didn't really touch on this, but the concept of skilled nursing facilities, nursing homes, there's a history of patients after joint replacement going to nursing homes, and that we've found more and more that may not be the best thing for patients. The risk of infection, the risk of wound healing issues, the risk of pressure ulcers is around 10 times higher if you're discharged to a nursing home rather than if you're discharged to home. So for that reason, that's why I have a big discussion with patients ahead of time. If they think that they're going to try to go to a nursing home after surgery, I really try to find out, is this absolutely necessary? Is there an alternative? Do you have family members nearby that would be willing to commit to your recovery to help reduce that risk for you? Because as we've seen, going to your home and recovering in your own home is by far the safest way for you to have a successful recovery. Yeah.
Is varicose veins a precursor to something that you would need to have dealt with prior to some
Question, yeah. So the question was, are varicose veins an issue for something that you need to have taken care of before surgery or anything like that? So varicose veins are just superficial veins around the skin that don't have any correlation to deep vein thrombosis, DVTs, or blood clots that we worry about before surgery. There are times when I've had patients who have some varicose veins that they run right across the place where I have to make an incision. And in those instances, it's not a big deal. It's something that we can address with just make sure that it stopped bleeding before we closed up the wound, maybe put an extra stitch in that or something. But they're not typically something you can really have anything done about ahead of time. And if you're going to have vein stripping or a vein procedure done anyways, sure. But it's not something you absolutely have to have done before an operation. Yeah.
what is the risk for blood clots?
So the risk for developing a blood clot in a patient who's never had a blood clot and has no other risks of blood clot. So that means they don't have a close family member who has a clotting disorder. They don't have a clotting disorder. Probably folks that aren't on birth control and patients who don't smoke. So if you're none of those things, your risk of developing blood clots less than 1%. And the things that we can do to prevent blood clots are we do give patients a blood thinner. For me, the low-risk patient that I described, I use a baby aspirin twice a day. So it's not Coumadin or warfarin, it's not Eliquis, it's not any of those expensive medications. Multiple large-scale studies have showed that aspirin is just as safe, just as effective as all those kind of toxins that you could take. And in a healthy, low-risk patient has less risk of bleeding and the same risk of blood clot. So really the best thing that anyone can do to prevent a blood clot is start walking, get around and get back to moving more normally, because it's nothing you can do better than just pumping your legs by walking across the hallway to help prevent blood clots. Yep. Yeah.
How about if you have a lot of arthritis in your back? If you get this epidural, will that?
Yeah. So the question was about an arthritic back and whether that has an effect on the epidural or the spinal anesthesia. Those are the folks that our anesthesiologists struggle a little bit with. They do a great job, though. I've seen some patients with terrible looking backs, or even some people that have had a fusion, and our anesthesiologists are able to quite literally thread the needle and get an effective spinal anesthesia. If they're not able to, we can do something called a total intravenous anesthesia, where we don't have to give people the gas. They just have a regular IV anesthesia, and that has a little bit, it has not quite as great as a spinal, but not as bad as a full general gas anesthesia. So there are other ways to help people get off to sleep without having to cause that big hangover. So.
Well, do they know that before they
Yep.
try it, like with the X-ray?
They'll know ahead of time, because one, you can't hunch over very well, and two, the patient usually says, "Hey, I've had a spine fusion." We can see it on their hip X-rays on the monitor there in the OR, so they know what kind of difficulty they're getting into. But they'll still try on most patients, just because even patients that have completely fused spines, they can oftentimes it'll still work. So it's something that they're exceptional at. They do a really great job here, and even if I had an arthritic fused spine, I'd say give it a shot, because it's not painful. It's just a matter of just giving it a go, make sure it works. Very good. Well, thank you guys all for coming. I really appreciate it. Again, thank you to Mosaic, and thank you to Zimmer Biomet for helping support this event. We're going to try to do some more of these events throughout Northwest Missouri. We like to get out into some of the communities, such as Maryville and Cameron, other places like that, to try to spread the word about my practice, my partner's practice, and what kind of things that we can help provide our community. I think that our overall goal here is to help provide care here in St. Joe that people used to leave town for. That people used to have to go to Kansas City to have an anterior approach hip. People used to have to go to Kansas City to have outpatient joint replacement. And we want to kind of prove to the community that you can get world-class care right here in your hometown, not have to go anywhere, have physicians who are incredibly accessible, and provide the best care we can. So again, thank you all for coming. I really do appreciate it. Great questions. And as we kind of mingle here, and if you get some refreshments and cookies over there, be sure to check out the implants that the folks from Zimmer Biomet have brought. I'll kind of hang over there too and answer any other questions you might have and show you the implants and things of that sort.
Does anybody in town do shoulders?
Yes, absolutely. Yeah. Okay. There was one last question about whether anyone in town does shoulders, and we do a whole lot of shoulder scopes. You probably mean shoulder replacements? Yeah, so of our partners, Dan Smith does a lot of shoulder replacements, so he's probably the guy right now to see that does a lot of shoulder replacements in town. Yep.
How about feet?
Feet, all of us treat feet to some degree.